Reviewing provider order sets for safe, early, continuous mobilization. We all know that mobility is key to recovery for all of our veterans, but it does not routinely happen unless it's ordered or protocolized. One of the biggest barriers that we see over and over again is whose job is it to mobilize veterans? When should a nurse mobilize? When is it a therapist's job? And when do we need a consult for therapy? The answer, of course, is that mobility is everybody's job, but providers can really help delineate those veterans who need a therapy consult and those who can be maintained at their current mobility level if they're at baseline by nursing. Appropriate consults for therapy can often mean the difference between therapists seeing the veterans who most need their skills versus spending time doing chart reviews or seeing veterans that could be up walking with nursing or with other non-therapist caregivers. And what we see is that for each 3 inappropriate consults, a therapist spends time reviewing the chart, determining if they're appropriate, only to find out that in fact they're not. For every 3 people that is inappropriate, that's 1 more veteran that could have seen a therapist that day and doesn't get seen by therapy. So it's really important that we get the right personnel mobilizing the veterans at the right time in a way that's safe for the veterans, safe for the caregiver. And what we've found is that standardized flow on order sets help to minimize the need for training and remembering to include the mobility and decide, is the veteran at baseline or not? Do they need therapy or can nursing mobilize them? Rather than trying to remember all that training, if it's built into the order set, our experience is that it's just so much easier. And nurses are used to following doctors' orders. And so if it's in the orders, the mobility on the nursing side is much, much more likely to happen. But we want to make it simple and straightforward. And we also have to remember that there's a lot of high turnover of residents, interns, and students. So we have to try and make it as easy as possible for everybody to be standardized in their practice. This is HRO 101. So let's look at those order sets and what this would look like in real time. We start by saying, initiate the early mobility order set. So that first brings up the question, what is the veteran's baseline or prior level of function? For this veteran, let's say they independently ambulate with no assistive device. The next screen is going to say, are they at their prior level of function? And so that you don't need to remember, we want a box to show up that says what their baseline is, and you can then say yes or no. So let's say this veteran is already at baseline. The next question is, are there any of the following conditions? Now, for this, if the patient's already, you've seen them walking, they probably don't have unstable fractures. But let's just say the patient has some unstable fractures. That's going to automatically populate to say bed rest, the reason why they're on bed rest, if mobility is contraindicated, order bed rest with reason, expires in 24 hours. Or some facilities say 48, some say 24. That's an item we need to discuss. But then again, it's going to pull up independently ambulates, no assistive device, so that we remember what this veteran's baseline was. But let's say there were no contraindications to mobility. Then we're going to hit no. And it's automatically going to populate initiate SECM per the SOP with no precautions. And remember down the bottom, baseline is independently ambulates, no assisted device. So we know what we're trying to get this veteran back to. But let's say there are precautions. Then we're going to say initiate SECM with precautions, and it's going to give us some options. Now, this is something we can discuss, but these are the most frequent precautions that we see. Let's say we want an immobilizer brace prior to mobilization. Then what we're going to see is initiate SECM with a precaution, immobilizer brace. Remember, the baseline is independently ambulates with no assistive device. So that's as quick and easy as it is. Check the box, initiate order set. What's their baseline? Are they at baseline? If yes, do they have any contraindications or precautions? Then you get to your order. If they're not at baseline, let's look and see what happens if they're not at baseline. Initiate or mobility. Let's say this patient has history of falls, near falls, cruises furniture, or walls at home. Are they at their prior level of mobility? And again, remember, this was the baseline. No, this person is not at their baseline. So where are they at? Let's say this person needs help to stand up. All right, there's no contraindications, but they're not at baseline. They're weaker than baseline, but there's no contraindications. If there were, you'd take back to that baseline or that bed rest screen with the reason, and then renew in 24 hours. If they're not at baseline and there are no contraindications to mobility, place the PT or OT consult. And let's look at your facility specifically with specifically what that entails. This is one example from a physical therapy consult where they required the provider to check if DME was needed before discharge to make sure that the purpose of and need for therapy was explained to the veteran and that they agree to participate. An exam has been performed by the physician and the veteran is appropriate for and capable of participating in therapy. So again, depending on what you have at Bay Pines, you might modify this. And then if there's any precautions with therapy, then you're going to add the precautions and you're done. Immobilize or brace prior to mobilization. So again, initiate mobility. What's their baseline? Are they at baseline now? Are there any contraindications to mobility? And this will be mirrored in your SOP. If there's contraindications, then we go to bed rest, review in 24 hours. If there's no contraindications, then we go to initiate SECM. If there's precautions, you're going to check those and you're done. If they're not at baseline, you're going to order therapy and then you're done. And then the last piece of the order set is renewing early mobility orders if you've had to pause them or hold for 24 hours. And really that's it. So let's discuss this on our meeting on Tuesday, and we can talk about the contraindications, the precautions, what that might look like. This is all flexible and can be changed, but we wanted to let you see what this might look like in real time. And then once we're done, we go back to the beginning and we're all set.